next speaker will be Dr. Fernando Santos. He'll be speaking again on single incision laparoscopic surgery versus standard surgery, comparison of performance using a surgical simulator.
Thank you for the opportunity to present. I have no personal financial disclosures. However, it should be noted that the Covidian instruments used in the study were provided free of charge. Single incision laparoscopic surgery, sometimes called SILS or other acronyms, has evolved as an alternative minimally invasive approach to standard multi-port laparoscopic surgery, which I will refer to as LAP. The concept of single incision techniques is the use of a single skin incision through which multiple surgical trocars or instruments are inserted, as opposed to multiple skin incisions with multiple trocars, as we know traditional laparoscopy. Some of the theoretical advantages of a SILS approach compared to a LAP technique include the potential for less pain and the potential for improved cosmesis, as a lot of times the scars can be hidden within the umbilicus. Since the first SILS cholecystectomy was performed in 1997, there have been an increasingly complex number of cases reported in the literature. However, there are several concerns that have been brought up in regards to the widespread adoption of SILS techniques replacing any laparoscopic techniques. These include so far, we do not have any evidence from large randomized trials showing an improved outcome for SILS operations compared to LAP. In addition, many of these procedures are being performed without any institutional review board supervision. Also, there has been no consensus on the need for formal training prior to the adoption of these more complicated techniques. Finally, the technical difficulty of SILS has never been directly compared to laparoscopic surgery. The learning curve of SILS has not been described. This is concerning given the increased potential of iatrogenic injuries early in the learning curve of any operation. In this study, we hypothesized that subjects performing SILS on a modified fundamentals of laparoscopic surgery trainer would be unable to match their performance compared to a traditional LAP technique. We also hypothesized that prior LAP or SILS experience would be beneficial for SILS performance. We had 3 predefined groups of experience for recruitment of subjects. These included completely inexperienced medical students all the way up to attending physicians with FLS certification, extensive laparoscopic experience, and at least 5 clinical SILS cases. The first simulator that we used was a standard FLS LAP simulator. This consists of 2 12mm ports that are comfortably spaced apart, as well as the use of standard laparoscopic instruments and an internally mounted camera. For the SILS technique, we adapted a custom-made cover to the FLS simulator. This cover was used to secure a SILS port, which we used for this study. We could have used an alternative type of port. However, we found that this port was very easily adapted to the simulator. In addition, the subjects performing SILS used articulating instruments and an endostitch device with articulation called the SILS stitch. Finally, to make the SILS technique more clinically relevant, we used a 5mm 30-degree laparoscope with a 90-degree light cord adapter, which was operated in standard fashion by a study proctor. The FLS tasks used were the standard FLS tasks with the exclusion of extracorporeal suturing. Testing protocol consisted of showing the subjects a 5-minute standard FLS video to familiarize them with doing the task. The subjects then performed the task using a laparoscopic simulator followed by a SILS simulator. In addition, the SILS experienced subjects were made to do additional suture trials in order to analyze the effect both of LAP versus SILS, as well as the use of a conventional needle driver versus an endo-stitch device. The scores were calculated using standard FLS scoring criteria that have been reported in the literature. These are based on the time and accuracy involved in performing the task. From this, we derived individual task scores as well as an overall score, which is an average of the individual task scores. Keep in mind that a passing score for these FLS tasks is on average 54%. Statistical analysis was performed using ANOVA. We had 27 subjects participate in the study. Of the SILS experienced subjects, we had 5 attending physicians. These physicians had performed an average of 22 previous SILS cases. This is a chart showing overall score for laparoscopic in blue versus SILS in green according to experienced group. As you can see, overall SILS score for each group was significantly lower than overall lap score for each group. This was statistically significant for all the groups. This line, the horizontal line represents the passing score for your reference. In terms of lap score, we saw an increase in lap score for the lap experienced group compared to the inexperienced group, which we expected. However, there was no difference between the lap experienced and the SILS experienced subjects. In terms of overall SILS score, lap experienced were better than the inexperienced, and the SILS experienced were better than the lap experienced. Keep in mind that there was a difference in the SILS score despite both of the top groups having the same lap score. In terms of individual tasks, as you can see, there is a big decrement in performance for most of the tasks when you compare lap to SILS. The only task that was similar was suturing. In terms of the individual scores by group, an interesting finding that we saw was that the inexperienced group actually performed SILS suture with the SILS stitch at a higher score than they performed lap suture with conventional needle drivers. In terms of the advanced suturing comparison done only by the SILS experienced subjects, we found that the use of the SILS stitch gave a higher performance than the conventional needle driver, but only in the SILS task. There was no difference in these instruments when used in a laparoscopic technique. In summary, we found that overall FLS performance was superior using a lap technique compared to a SILS technique, and this was true at all experience levels. In addition, surgeons with previous SILS experience performed significantly better than those with only lap experience, despite having similar lap scores. The SILS experienced group were the only ones to achieve a mean overall passing score using SILS. In addition, we found that for suturing and SILS, this score was better using a SILS stitch compared to the use of a conventional needle driver. I should acknowledge some limitations that we did have in the study. The first being that this was performed in a controlled laboratory setting, which facilitated the standardization of the examination. However, it is sometimes not easy to generalize from this. In addition, we could have used alternative ports. However, given many of the ports used for these single incision techniques are very similar, I'm not sure that the results of the study would have been significantly different. In addition, we did have a small number of participants. However, we did see statistically significant differences between the two techniques. Another consideration is that perhaps we examined the SILS experienced group too early in their learning curve. It's impossible to say, perhaps, what the performance level would be after a more extensive SILS experience. In conclusion, I think the results of this study show that we need to take a cautious approach to the adoption of SILS, given the increased technical difficulty and the inferior performance that we saw compared to a lap technique. In addition, I think there should be consideration given to perhaps increasing IRB oversight for some of these procedures. In addition, I think the results of the study argue for the creation of some formal training prior to the performance of these more advanced SILS procedures. Finally, I think the results of the study show that there is some improvement that we can make with instruments. Thank you.